Thank you, Dr. Vidya, for the warm introduction, and thanks to Georgie sir for the opportunity and for suggesting this topic. Let's try to understand this topic with a clinical case. A 12-year-old boy is referred to nephrology after a urine analysis shows persistent microscopic hematuria with no proteins or cast. He has no edema, no hypertension, no gross hematuria. His growth and development are normal. He mentions occasional difficulty hearing his teacher in noisy classrooms, but his parents thought it was normal. This is often the typical presentation in Alport's disease. Alport syndrome is a progressive hereditary disorder of basement membrane. The incidence is about 1 in 50,000. It accounts for about 1.3% of pediatric end-stage kidney disease and 0.4% of adult end-stage kidney disease in the United States. Alport syndrome is underdiagnosed in India. High rates of consanguineous marriages in some communities may increase the frequency of autosomal recessive Alport syndrome. While there are no nationwide epidemiological studies from India, a recent single-center cohort identified 43 genetically confirmed cases over 8 years, with X-linked disease being the most common. Improved genetic testing is helping us recognize more cases. Before we move forward, let's stop for a poll. Over to you, Dr. Vidya.
So, this is a first poll. A normal hearing test or a normal audiogram in a 5-year-old boy does not rule out Alport syndrome. Enumerate the reasons. A. Hearing loss is only found in autosomal dominant form. B. Hearing loss typically develops in the second decade of life. C. The hearing loss only affects low frequencies first. D. The auditory defect is transient and only occurs during hematuria bouts. Can you please launch the poll? Can you please close the poll and launch the results? Okay. Edwin, sir, you will be definitely having more Alport syndrome patients there, sir. How early do you see sensory neural hearing loss, and how is the follow-up screening or monitoring done in these patients, sir? Edwin, sir? I think sir is not there. The answer is hearing loss typically develops in the second decade of life. Can we continue with the presentation?
Yes. So as shown in this diagram, the glomerular basement membrane is a key filtration barrier in the kidney. Collagen type 4 is its major structural component, providing strength and support. In Alport syndrome, genetic mutations disrupt this network, making the basement membrane fragile. Collagen 4 is a part of cochlea and eyes, resulting in sensory neural hearing loss and ocular manifestations. So mammals have 6 types of collagen 4 genes, namely alpha 1 through alpha 6. These 6 genes can assemble with each other to form heterotrimers that are found in tissue basement membranes. The call for A1 and A2 forms the alpha 112 trimer found in endothelial basement membrane and the mesangial matrix. Then in glomerular basement membrane, there is alpha 345 heterotrimer. And then there is alpha 5, alpha 6 heterotrimer present in Bowman's capsule basement membrane. Normally, the alpha 3, alpha 4, and alpha 5 chains of type 4 collagen come together to form a triple helix, which forms tetramers, and that's the ultimate alpha 345 network within the glomerular basement membrane. So it's very specifically close linked to provide that strength to the basement membrane. In the developing kidney, Glomerular basement membrane is initially made of alpha 1 and alpha 2 network. Now, as the glomerulus matures, mainly in the first few years of life, there's a developmental isoform switch from the alpha 1 1 2 to the stronger alpha 3 4 5 network. Issues with this switch leads to Alport syndrome, which presents initially as hematuria after infancy, and the disease progresses over time. In severe cases, the kidney may try to compensate by keeping more alpha 1 1 2, but then this is not strong enough for lifelong filtration stress, leading to progressive damage, lamellation, and fibrosis. The gene for alpha 5 chain is on the X chromosome, and mutation of this gene leads to X-linked disease. The genes for alpha 3 and alpha 4 chain are on the chromosome 2, and mutations here leads to autosomal disease. When there is a severe COL4A5 mutation, the alpha 5 is not expressed, and the normal alpha 3 and alpha 4 can't form the triple helix and end up getting degraded, thus resulting in a severe Alport phenotype. A mild COL4A5 may still express alpha 5, and this happens in about 20 to 30% of patients with Alport syndrome, where they can still form the alpha helix. So there will be some form of alpha 3 4 5 network in the basement membrane, but not just enough. And these patients often have a milder phenotype. It's time for another poll. Over to you, Dr. Vidya.
We'll go move on with the second poll. Which genetic mechanism explains the wide variability in clinical severity among females with X-linked Alport syndrome? A. Digenic inheritance from both parents. B. Contiguous gene deletions. Or C. De novo mutations in the second allele. Or random X chromosome inactivation or lionization. Can you please launch the poll? Can we close the poll and launch the results? So 71% have answered as lionization. Edwin sir, are you here, sir?
Yes. Can you hear me?
Yes, sir. Yes, sir. Sir,
Right. So the right answer would be D, as most participants have answered, random X chromosome inactivation. The proportion of cells expressing the mutant versus the wild type. So the X chromosome determines the mosaicism of the functional collagen in the GBM. So this is the reason why this is a genetic mechanism that explains a very wide variability among females, because in fact, in many females, we can even take them as donors because they have a very mild form of disease and generally don't manifest anything till about 45, and sometimes they just have microscopic hematuria, and the mothers could be very safe donors. So the right answer would be the random X chromosome inactivation by a process also known as lionization.
Okay, sir. Thank you, sir. We'll move on with the presentation.
Now, taking a peek back into a clinical case, looking at the family history, that 12-year-old boy's maternal grandfather reached ESRD at the age of 28 years and was on dialysis. His mother, aged 38, has had lifelong hematuria, but normal kidney function so far, and has mild sensorineural hearing loss. One maternal uncle had a kidney transplant in his 30s. There is no similar history on the father's side. Now, why is there a varied pattern in the same family? What we see here is a spectrum of the same disorder. Like Georges has said, historically, Alport syndrome was described in 1927 by Cecil Alport as a rare disease affecting young males, leading to progressive kidney failure, sensory neural deafness, and eye abnormalities. However, with the discovery of responsible genes, that is called for A3, A4, and A5, and widespread genetic testing, we realized something important. This condition is not a single entity. It is a spectrum of a disease. So in 2018, the Alport syndrome classification working group led by Dr. Clifford Cashton published a landmark paper in Kidney International proposing to unify all genetic disorders of collagen 4 alpha 345 network under the umbrella of Alport spectrum disorders. This change was made for two main reasons. One, they all share the same molecular defect, that is abnormal type 4 collagen in basement membrane. Second, even the milder forms carry a risk of progression and benefit from early monitoring and treatment. If you look at this slide, on the left in purple, we have the mildest forms previously called benign familial hematuria or thin basement membrane nephropathy. These are usually due to heterozygous mutations in COL4A3 or COL4A4, COL4A3 or COL4A4. These patients typically have isolated hematuria within the glomerular basement membrane on biopsy. Now we have to as we move to right, the disease severity increases. So female carriers of X-linked Alport show high variable disease, while on far right in red we see the classical severe form seen in males with X-linked Alports and also in patients with autosomal recessive disease. So these patients develop proteinuria, progressive kidney failure, hearing loss, and eye abnormalities. The important message here is that Alport is not one disease, but a spectrum, and management decisions should be guided by both genotype and clinical features. We saw in the clinical case that the child had persistent microscopic hematuria. Now, on the approach of microhematuria, I had earlier spoken in one of our earlier ECNG classes. So here we'll keep the approach part just to the point. So the majority of patients with isolated glomerular hematuria fall in one of the four categories. That is IgA nephropathy, genetic variants of COL4, A3, A4, and A5, meaning Alport spectrum disorder. It can be C3 glomerulopathy or thin basement membrane disease without an identifiable genetic variant. So these are the recommendations made by the International Pediatric Society of Nephrology on evaluating a case of persistent isolated glomerular hematuria. In patients with family history of hematuria, CKD, or history of bilateral sensory neural hearing loss, genetic testing is recommended as the initial study. In patients without a positive history, a kidney biopsy that includes electron microscopy is recommended first. If a pathogenic variant of collagen 4 mutation is found, we manage this patient as having Alport syndrome, including early ACE inhibitors and ARB therapy, regular monitoring, and family screening. Now, if the suspicion is low, we perform a kidney biopsy. Characteristic findings, especially on electron microscopy and collagen 4 immunofluorescence, about which I shall talk shortly, can still support the diagnosis. Importantly, even if genetic testing is negative or inconclusive, we do not rule out Alports if the overall picture fits in. These patients still benefit from the same management approach. Majority of the cases are X-linked Alport syndrome with COL4A5 mutations. Males are hemizygous with nearly 100% risk of progressing to ESRD, usually by the age of 20 to 40. Females are heterozygous, so much lower risk with less than 25% reaching ESRD. But again, as Edwin sir mentioned earlier, this is highly variable due to X inactivation. Then there are autosomal varieties, including COL4A3 and COL4A4 genes. These can be recessive with homozygous or compound heterozygous genes. Homozygous means both copies of the genes carry the exact same pathogenic mutation. And compound heterozygous means the two copies of genes carry two different pathogenic mutations. And both these have a risk of have a 100% risk of ESRD in both sexes, often with early onset. Now, the dominant variety is heterozygous, so it's generally milder. Risk of ESRD can go above 20% if additional risk factors are present. So when we say additional risk factors for progression, these are the presence of FSGS, the presence of proteinuria, factors like hypertension, obesity, smoking, mutations like deletions, truncating mutations, etc. So if there are no additional risk factors, then the risk of progression is just less than 1% in the autosomal dominant category. Now, rarely there are digenic varieties, which are very rare, where there are combinations of multiple COL4 genes. Now, X-linked Alport syndrome, the risk of ESRD in males with Alport syndrome is about 50. X-linked Alport syndrome is about 50% by the age of 25 years, and about 80% of them go to ESRD by the age 40. So here there's a real risk, and you can see even in early to mid-teen years there's a risk of end-stage kidney disease. For women with X-linked Alports, there's about a 12% risk by about the age of 40 years and a 30% risk by the age of 60 years. Now, a key reason for the variable severity in female carriers of X-linked Alport syndrome is X chromosome inactivation, also known as lionization. So as shown in this diagram, early in the embryonic development, each cell inactivates one of its 2 X chromosomes. This inactivation is then passed on to all daughter cells, here designated with the red ink. As a result, females become a mosaic. Some cells express the call for A5 gene, while others express the mutated copy. This leads to patchy or mosaic pattern, designated in pink colors here. So the degree of this mosaicism explains why some female carriers have only mild hematuria, while a few can develop significant kidney disease. Now, this X inactivation influences the disease severity. So if a female is skewed more towards the normal side, she may just have a little bit of hematuria and proteinuria. Now, while this female is skewed more towards the mutant allele, she will have ESRD, hearing loss, or eye problems. Unfortunately, there is no convenient way to measure this X inactivation. Now, patients with autosomal recessive Alport syndrome behave very similar to men with X-linked Alport syndrome, meaning they have a severe disease. The risk of ESRD is 50% by the age of 20 years. Patients with autosomal dominant Alport syndrome have much later onset of disease, as I described earlier, and their median age of end-stage kidney disease is about 67 years. And the timing here is very similar. Whether it's called for A3 mutation or called for A4 mutation. Now, the timing of ESRD is again similar whether the mutations are truncating or even if it is just missense mutation in the case of autosomal dominant Alport syndrome, unlike the case in X-linked Alport syndrome. Now let's go to another poll. Over to you, Dr. Vidya.
Thank you, sir. So the third poll, according to the 2024 guidelines, what is the recommended clinical management for an asymptomatic female carrier of an X-linked pathogenic variant? A. Biannual kidney biopsies to monitor for basket weave lamelation. B. Treatment with ramipril only once low-level albuminuria is detected. C. Avoidance of RAS blockade due to the risk of inducing anti-GBM disease. D. Initiation of RAS blockade immediately upon genetic diagnosis. Please launch the poll. Please close the poll and launch the results. So 40% have polled like treatment with ramipril on detection of albuminuria. Edwin sir, your practical input, sir.
Yeah, I think it should be the correct answer should be B. So if we look at the current guidelines, they suggest starting treatment in X-linked Alport females and autosomal dominant Alport syndrome patients at the onset of low-level albuminuria, as they have a lower risk of early kidney failure. Biannual kidney biopsies are not standard practice and not practically possible. Monitoring is primarily performed through urinary sediment analysis and albuminuria levels. Unlike autosomal recessive and X-linked males, immediate treatment is not mandatory for X-linked Alport syndrome females until clinical markers like albuminuria appear. So the correct answer should be B. Treatment with ramipril only once low-level albuminuria is detected. So it need not be initiated immediately upon genetic diagnosis.
So microhematuria will monitor.
Yes, you monitor. Correct.
Yes. Move on to the presentation.
Let's take a look at the biopsy findings now. In light microscopy, in the earlier stages, there are no morphological changes. However, as the disease progresses, segmental sclerosis occurs, especially in the perihilar region. And later, there is advanced disease. And then in the interstitium, we can find formed cells. And in very advanced cases, there is diffuse glomulosclerosis with interstitial fibrosis and tubular atrophy. Coming to the immunofluorescence, usually biopsy is negative for immune deposits. So this helps rule out immune-mediated glomerulonephritis like IgA nephropathy, membranous nephropathy, lupus, and these things can sometimes coexist with or mimic Alports. However, there is something called specialized immunofluorescence for collagen 4 chain, which I mentioned earlier. So this gives a lot of information. Here, labs use monoclonal antibodies against alpha-3, alpha-4, and alpha-5 chains of type 4 collagen. So in this image, you can see immunofluorescence for alpha-5 chain. So here, it's normal in heterozygotes, with alpha chain being positive in the glomerulus and in the Bowman's capsule and in the distal tubular basement membrane. So this is normal. In X-linked autosomal female, some part of the glomeruli are positive and some part are negative. In autosomal recessive, alpha-5 is negative in glomerular basement membrane and positive in the Bowman's capsule and in the distal tubular basement membrane. Now coming to X-linked male patient, there is no alpha chain at all. So everything is negative, whether it's the glomerulus, the tubular basement membrane or the Bowman's capsule basement membrane, everything is negative in X-linked Alport syndrome male patient. No, this is just a summary of the patterns you will see when you stain with special immunofluorescence. So these patterns help differentiate X-linked versus autosomal recessive forms. In X-linked Alport syndrome, where there is called 4A5 mutation, the defect is in the alpha-5 chain. Now, because the other two chains depend on the alpha-5 chain, the proper assembly and incorporation into the glomerular basement membrane does not take place. So loss of alpha-5 usually leads to the loss of the entire alpha-3, 4, 5 network in the GBM. Whereas in autosomal recessive Alports, the primary defect is in the alpha-3 or alpha-4. The alpha-5 chain can still be produced, but even then it cannot properly assemble into the GBM without alpha-3 and 4. However, alpha-5 chain can still appear normally in the other basement membranes like the Bowman's capsule and the distal tubular basement membrane, which I showed earlier. So absent alpha-5 in both GBM and Bowman's capsule and tubules strongly suggest X-linked male Alport syndrome. Whereas if the alpha-5 is absent only in the GBM, whereas it is preserved in the Bowman's capsule and distal tubular membrane, it suggests autosomal recessive. So in a way, this special immunofluorescence helps you differentiate X-linked male Alports and autosomal recessive Alports. But nowadays we have genetic testing, which is in fact cheaper and easily available. So this is not often necessary. Now, what is a practical application of this special immunofluorescence? So it can confirm whether the diagnosis when EM shows characteristic GBM changes like thinning and lamelation. It can identify carriers, especially female X-linked carriers with mosaic pattern. It supports the diagnosis when genetic testing is not immediately available or when it is inconclusive. It also has a prognostic value, that is loss of alpha-5 chain. Loss of alpha-5 staining often correlates with severe disease and faster progression. In some cases, if the patient is not willing for a kidney biopsy, especially in X-linked males, a skin biopsy and staining it for immunofluorescence for alpha-5 chain can be a less invasive option. Now, this is a study which showed patients who have alpha-5 chain in their basement membrane have been found to have a milder disease. And this study is from Japan, where they looked at 146 patients with Alport syndrome. And in this study, they found that patients with negative alpha-5 progress to ESRD at a faster rate compared to those with a positive alpha-5. Now, coming to the electron microscopy, thin glomerular basement membrane is a key finding on electron microscopy in Alport spectrum disorders, and it has major diagnostic and prognostic importance. According to the WHO criteria, for adults, regardless of gender, everything below 250 nanometers is thin basement membrane, and everything below 180 nanometers for children below 11 years is thin basement membrane. This thin basement membrane nephropathy is now widely regarded as a mild end of Alport spectrum rather than a completely separate benign disease as was thought earlier. These patients too require genetic testing, family screening, regular monitoring, and early RAS inhibition if proteinuria or other risk factors appear. Now, when you find thin basement membrane, the possibilities are various. One of the possibilities could be you are looking at an early X-linked male Alports or a milder form of Alports. So while many of these patients with thin basement membrane remain stable with only hematuria, we now recognize that thin glomerular basement membrane with COLD4 variants is not always benign. It represents the mild end of the same disease spectrum and warrants genetic testing, family screening, and lifelong monitoring. In the later stages in electron microscopy, we see glomerular basement membrane thickening and podocyte effacement. And then there is this basket weaving type of appearance, which is the striped sort of appearance of the basement membrane that you can see towards the top of the screen. Coming to the next poll, over to you, Dr. Vidya.
Yes, sir. So the fourth poll, the early PROTECT trial demonstrated the safety and efficacy of which treatment in children with Alport syndrome? A. Dapagliflozin, B. Bardoxolone methyl, C. Ramipril dosage in children, C. D. Anti-MIR-21 therapy. Please launch the poll. Please close the poll and launch the results. So 48% have opted for Ramipril dosage in kids, sir. Sir, Edwin, sir, please share your experience regarding treatment of Alport syndrome in children, sir.
So this is the early PROTECT trial. This trial tried to demonstrate the safety and efficacy of Ramipril. So the right answer here is C, Ramipril. So this is a phase 3 trial. It confirmed that early Ramipril therapy in children is safe and effective in delaying disease progression. The other drug that is of interest is the Ledimycin. These trials were terminated due to futility and failure to show improvement in eGFR decline. Bardoxolone was used earlier in CKD also. The Cardinal trial was stopped early due to safety concerns and increased risk of ESRD. Meanwhile, we do not have any evidence for SGLT2 inhibition in patients with Alport. A few words about the anti-microRNA 21. This is a synthetic engineered oligonucleotide designed to inhibit the expression and function of the microRNA. This is supposed to be something called an oncomere that is often overexpressed in cancer and fibrotic diseases. By silencing the MIR-21, anti-MIR-21 treatments reduce tumor growth in melanoma and liver cancer and prevent fibrosis in Alport syndrome and lungs. So this was actually discussed way back in 2015-14 itself, where they looked into mouse models that showed that these anti-microRNA 21 oligonucleotides prevent Alport's nephropathy progression by stimulating a lot of metabolic pathways. However, this has not been, did not translate effectively into humans later. So the right answer will be the ramipril dose. The early PROTECT trial looked at ramipril dosage in kids.
Okay, sir. Thank you, sir.
Now, it is important to understand the mechanism of the disease for effective therapeutic management. Although Alport syndrome starts with a genetic defect in the type 4 collagen, the progression of kidney damage involves many secondary mechanisms. As shown in this diagram, the initially thin and fragile glomerular basement membrane triggers multiple cell types to respond inappropriately. Podocytes upregulate matrix metalloproteinases and invade the glomerular basement membrane with pilopodia. Endothelial cells produce more endothelin-1, while mesangial cells and other kidney cells release inflammatory mediators. Over time, this leads to abnormal matrix deposition, including laminin 211, leading to chronic inflammation, fibrosis, and the classic basket weave appearance we see on electron microscopy. Understanding these downstream pathways is important because there are several ongoing clinical trials with endothelin antagonists, NOx inhibitors, antifibrotic agents, etc., targeting these mechanisms. One of the cornerstones of Alport syndrome treatment is RAS inhibition. As shown in this diagram, these medications like AC inhibitors or ARBs, they work by dilating the efferent arteriole. This reduces the high pressure inside the glomerulus, which reduces the glomerular hyperfiltration and which occurs in the kidneys as the basement membrane tries to compensate for the weak alpha 112 structure. Now, by lowering this intraglomerular pressure, we reduce the mechanical stress on the fragile GPM, thereby decreasing proteinuria and significantly slowing the decline of kidney function. Now, this benefit is even seen in patients with normal BP, which is why early initiation is recommended. This slide is from a Japanese study by Yamamura and team, published in Kidney International in 2020. It clearly shows the impact of both mutation type and treatment. So patients with truncating mutations have the worst prognosis. So without treatment, these patients reach kidney failure at a median age of about only 16 years. With AC inhibitors or ARB treatment, this can improve to 28 years. Patients with non-truncating mutations do much better. Without treatment, the median age to kidney failure is 33 years in non-truncating mutations. But if you give them AC inhibitor or ARB therapy, many will still have preserved kidney function well beyond 50 years of age. This data strongly supports our current practice of early RAS inhibition in Alport spectrum disorders, especially in patients with high risk and those with truncating mutations. This slide is from a study published in NDT by Beckes and team and shows the dramatic benefit of early treatment in patients with a specific missense mutations, which is a milder form of mutation. In this cohort of 114 patients with the same mutation, all men who were untreated or started AC inhibitors late, which means those patients who were started after the GFR fell below 60 eventually reached ESRD. In striking contrast, none of the men who received early RAS inhibitor treatment progressed to kidney failure. So this is a powerful evidence that early RAS blockade can be disease modifying and in some milder genotypes may even prevent the need for dialysis or kidney transplant. Now let's look at the evidence behind our current treatment. This timeline summarizes key therapeutic studies in Alport syndrome over the last 20 years. It started with animal models around 2003 to 2010, showing that early ramipril significantly prolonged lifespan and reduced kidney damage. This led to human studies, particularly the European Alport registry, which demonstrated that early initiation of AC inhibitors delays the need for dialysis and reduces proteinuria. Multiple trials in children with losartan, enalapril, etc. confirmed safety and efficacy. By 2020, data showed that starting treatment even in stage of isolated hematuria or microalbuminuria, which is the early protect approach, is beneficial and safe. This strong body of evidence is why early RAS blockade is currently the standard of care for all patients with Alport spectrum disorder who have proteinuria or who are at a high risk of progression. So if starting AC inhibitors in patients with Alport syndrome is good, how early should we be starting these drugs? So this is the early protect trial that was published a couple of years ago, trying to answer the question of whether starting AC inhibitors in children before they even develop proteinuria can be beneficial. So this study randomized children to Ramipil or placebo. These kids were between the age of 2 and 18 years, and they either just had isolated hematuria or microalbuminuria, meaning they were recruited in a very early stage. And all these patients had normal GFR and normal blood pressures. There was no safety signal and the drug was well tolerated. Early Ramipil treatment slowed the disease progression, particularly the development and increase of albuminuria and the increase of albuminuria. So this benefit was very high in the Ramipil group, approximately 1.5 to 3 times better than the placebo. While RAS inhibition remains the current standard of care, the therapeutic landscape for Alport syndrome is rapidly evolving. Now, this slide shows ongoing clinical trials, specifically including Alport patients. So, there are trials ongoing with endothelin receptor antagonists like atrasentan and sparsentan, SGLT2 inhibitors like dapagliflozin, antifibrotic drugs like cetaxanib and vonapexor, and even a mutation-specific therapy, ELX02, for patients, especially with nonsense mutations. Now, the fact that these are multiple active trials is very encouraging. These new therapies used on top of RAS inhibition may change the scenario of RAS inhibitors in future. Now, there are certain therapeutic recommendations for Alport syndrome. So consider Alport syndrome diagnosis if patients have isolated persistent glomerular hematuria, normal complements, negative serology. Do a genetic testing if there is family history of Alports. Do a kidney biopsy if there is no family history or if genetic testing is inconclusive. Now, when to start AC inhibitors or ARBs? So if the patient has X-linked Alport syndrome and if it's a male, at the time of diagnosis, we should start AC inhibitors or ARBs. If the age is, for those people who are about 12 to 24 months of age. Now, in X-linked Alport syndrome female, classified as Alport syndrome and not as carriers, if there is microalbuminuria, you will have to start them on AC inhibitors or ARBs. If the patient is autosomal recessive, again, they are of higher risk like the X-linked Alport male category, and these patients should be started on Alport syndrome at the time of diagnosis, irrespective of whether they have microalbuminuria or not. Those patients with autosomal dominant Alport syndrome, they are at a very slow risk of progression. So if there is microalbuminuria, then we can start them on AC inhibitors or ARBs. Now, what to monitor? So BP control is very important. So unlike the general hypertension guidelines, in Alport syndrome, we aim for a low normal blood pressure, that is around 50th percentile, because even normal pressure can damage the fragile GBM over time. So this combined with early RAS inhibition is one of the most effective tools we currently have to slow the disease progression. So these patients also require comprehensive annual hearing evaluation from the age of 5 to 6 years, especially those with X-linked Alport syndrome males and autosomal recessive males and females. Annual eye examination is necessary from the age of 15 years. And patients planning pregnancy and menstruating patients planning pregnancy, it is necessary to tell them regarding the cessation of AC inhibitors and ARBs before planning to become pregnant. Now, here are a few points to remember. A negative family history does not exclude Alport syndrome. So many cases are due to de novo mutations. In X-linked Alports, females may have very mild or no symptoms, so the family history can look negative. So the take-home point here is always consider Alports even if there is no obvious family history. Now, a positive family history of CKD is not proof of Alport syndrome. There can be other hereditary kidney diseases like Fabry's disease or nephrosis. These can also run in families. So the family history raises suspicion but requires confirmation with genetic study or a biopsy. Now, absence of specific findings like hearing loss or ocular abnormalities does not exclude Alport syndrome. This is because extrarenal manifestations are often age-dependent, genotype-dependent, and sex-dependent. So many patients, especially young children or heterozygous females, have only kidney involvement at presentation. So the take-home point here is isolated hematuria can still be Alports. So don't wait for deafness or eye changes to make the diagnosis. Finding a thin basement membrane on EM does not guarantee non-progressive disease. So thin GBM was previously called benign familial hematuria. However, it is not considered benign anymore. So we now know that many of these patients have called for variants and still can progress to proteinuria and CKD over time. So the take-home message here is this thin basement membrane belongs to the Alport spectrum and it is not always benign. Some patients with clinical and pathological findings of Alport syndrome may have negative genetic testing. The reason for that is there can be large deletions or rearrangements missed by standard sequencing. There can be mutations in regulatory gene regions. There can be digenic inheritance, or there can be unknown genes. So the take-home message is a negative genetic test does not completely rule out Alports, even if clinical and biopsy findings are. It does not rule out Alports. So these patients should still be, if the clinical and biopsy findings are suggestive of Alports, these patients should still be managed as Alport spectrum, and they often benefit with